Welcome to the Resilient Performance Podcast. This is Keep It Real number 28. We're going to talk about strength and pain today and the correlation or not correlation. I don't know if not correlation is a phrase, but we'll just talk about that. Take it and run with it, Doug.
Yeah, so I'm seeing on social media, there's people sharing research saying that, for example, if you have patellofemoral pain, that eliciting strength gains doesn't necessarily make that better. Or if you have, shoulder pain, that strengthening the rotator cuff doesn't necessarily make that better. And I think that that's very fair because there's plenty of people that probably, we could look at and say, well, you seem like you're weak by these objective tests, but there are also people who would test a lot weaker in the same test and might not have pain. So to say that strength training, for example, doesn't make pain go away, I think is fair. But I think like a lot of this stuff, it's ultimately a matter of semantics because it really depends on how do you define strength training. And I'm not saying that strength training is this panacea, but at the same time, most physical therapists and rehab providers agree on the concept of graded exposure. And a well-structured strength training is essentially graded exposure. So really when someone's working with pain, you might not care about strength per se, but I look at a responsible strength training program as just systematically applied stress. It's stress inoculation. You're trying to, gradually ramp up someone's ability to tolerate physical stress in an area where there might be pain. So a good strength training program for somebody in pain is essentially getting them to do things that don't elicit symptoms, or at least don't exacerbate symptoms beyond the baseline level, and then building up their tolerance for movement until they can do higher level things and ultimately reach their functional goal. And the goal of a training or a rehab environment in an artificial sense is to basically create a stress buffer so that whatever you're doing in that artificial environment is surpasses what you want to be able to do in real life, so that you're kind of slightly over prepared for what you want to encounter. So again, I think it comes down to how do you define strength training? But I think it is ultimately a matter of semantics, because even if you look at the people that think they're strengthening things in our field, I mean, the reality is most people are doing things like clamshells and banded rotator cuff exercises and calling that strength training. I don't think there's this epidemic of physical therapists who have people doing these maximal effort strength programs and heavy deadlifts and squats and whatever exercise you want to do, barbell or even dumbbell based movements. Most of it's pretty, I would say, benign. And even people who say that they're strengthening, let's say, the glutes, how much is doing a program consisting mainly of band walks and clamshells really strengthening the glutes? If that does work and it, in air quotes, work, and it makes somebody, it resolves their symptoms, it's really because it's just graded exposure and desensitization. They're not really, gaining strength or hypertrophy, things that you would associate with more of a strength program. So I think a lot of times what people say they're doing, what they're actually doing are different. But I think it's good to really be accurate with our language and say we're not, strength training doesn't make people symptom free per se. I think it's a totally fair statement. But from a practical standpoint, I would say the most important part of a rehab program is graded exposure and exercise. And a lot of that looks like a responsibly applied strength training program, even if we're not eliciting strength gains per se. So what are your guys' thoughts on that?
I think strength is super protective, and that's one of the reasons why I think, we do a lot of things that are kind of look like strength-based movements. And I don't always go into it with the lens of thinking that I need to strengthen a certain muscle based upon their MMT or based upon some sort of objective measurement that this specific muscle is weak. But we kind of look at more in the totality of what that area of their body and what their body as a whole needs to be able to do. And like you've been saying, Doug, it's strength training, I think, is a really great way. That's ultimately just another form of graded exposure, but it's also a great way to help desensitize whatever part of the body part of the body that the person may be having symptoms with. So gradually increasing how much force that part of their body can absorb or produce is just another form of graded exposure. And maybe their MMT may not look different, or however we're measuring it with like a handheld dynamometer, it doesn't really matter. But if they can do more things with less symptoms, it doesn't really matter if the person's, necessarily got quote unquote stronger, or if we are putting muscle mass onto that area of their body. Like that's usually not our goal. We're usually not working with people for that like long-term, unless post-op case where like we have 8 to 12 weeks to literally pack on muscle. That's kind of an extreme example, which we are 100% doing strength training for kind of hypertrophy and some of those other physiologic benefits. Yeah, like I think training is really important, and I think strength training is a really good way to like help people build confidence. And like so many times we'll have teach somebody a kettlebell deadlift, and it's not to strengthen this specific muscle, but it's like in your day-to-day life you got to be able to pick stuff up off the floor. And if they can pick that kettlebell up and gradually do it with heavier and heavier weights, like I don't really care about the specific muscles that I'm strengthening, but I know that we are helping them be safer when they have to do a lot of things that they're going to have to do in their day-to-day life.
And then we just talk about output, right? We've spoken before about just like having a high output, no matter what it is. It's like you just try and find, within constraints of like a rehab situation or pain, like you find what situations you can put somebody in, what positions you can put somebody in where they can still produce output, because we don't want to lose generally in any way output for people. So if they can't sprint, it's like, all right, what's a stressful way we can apply a load to them with speed that, and maybe it's a bike, like we've spoken about previously on a different episode with a hamstring strain, for example. Like you just find another way where they can quote unquote sprint, and it might be a bike for a hamstring strain as an example. And then, yeah, like there's plenty of research that you have to work at like 80% of your max or something like that to even elicit some sort of strength gain physiologically. So like you say, Doug, if you're just kind of doing band exercises and like, it seems like we're just bashing that stuff, which we sort of are a little bit, but like if that's all you do, that's a problem. But like there's no way that band is eliciting 80% of your max, muscle activity or whatever metric is used to create an actual strength stimulus. So then it's like these band exercises cured my pain, but it's like, well, is it that, or did you just like stop doing did you stop poking the bear? Did you stop doing the thing that caused you pain because you were in pain and you like went to a doctor and they told you can't do something? And that's a lot of times what I see happen, especially with my throwers. It's like, I've had this pain forever. So like eventually it got, bad enough where I went to this orthopedist and they shut me down. It's like the doctor shut them down. So then therefore they're no longer allowed to do something that has hurt them forever. And then they wind up with me, and I'm just like managing workloads essentially. Like that's the hardest part, I think, with treating baseball or throwers is like, because I was a thrower and did throw, which we often with other sports might not value as much, but like going through throwing programs my entire life and understanding like how to appropriately apply the throwing stresses to somebody is kind of something you need to know to manage a thrower. Because all I'm really doing is managing them, really. Like it's like, yeah, we'll do some soft tissue, and yeah, we'll do some band shit and whatever, kind of correct whatever like postural, positional alignment things you might not be the best they could be. But essentially, it's like if I can't manage your throwing, intensity and volume and workload over these next 4, 6, 8 weeks to get you back to throwing, like you're not going to be better. You're going to be the same person, just 8 weeks from where you were when you started with me. So that's something that I find really important.
I think another piece of it too, when it comes to like looking at like the research stuff that's based upon like strength and pains, like we're only taking kind of two variables, so to speak, and just trying to find if those two things match. And there's so many other variables that are really important. And like the example I was kind of thinking of with Greg talking about like throwers and stuff is like an athlete that like, what if somebody has pain when they do push-ups, and like that's what hurts, and therefore they got an MRI and they found some sort of like pathology in their arm. So then when you watch them do a push-up, their shoulder blade is coming off of their rib cage. So the PT school kind of strengthening exercises would be like low trap stuff, serratus anterior, like supine, weighted like serratus punches, things like that. It's like you could do those exercises until the cows come home. But if the person just doesn't know how to do push-ups, like it doesn't matter if you got those two muscles from a handheld dynamometer standpoint, like 10,000 times stronger, because they still do push-ups with crappy form. So it's like, okay, so what is the kind of lens that we're kind of choosing what we need to strengthen, and B, like what are the actual interventions to strengthen things? So
And then if you're doing like serratus punches and you just go back to throwing, like nothing's different. You should take your serratus punches and turn them into like landmine presses and actually be getting stronger in a different position where it's, similar, whatever. If you're attacking the serratus for whatever reason, you're just attacking the position of the scap and the humerus overhead. So just to kind of piggyback.
Just like taking like just the basic strengthening and like almost like linear periodization for like adding more weight over time or increasing the volume and keeping the intensity the same. It's like, well, how about progressing some of those other variables within the movement itself, like kind of Greg said, like going to a kind of a different range of motion, to going to a landmine press, going to a landmine push press, going to a band resisted landmine push press, where it's kind of more of a ballistic action. Like there's so many other variables and ways we can progress things that you can use the term more functional, which I don't think any of us necessarily like that term, but you're just doing something that's a little bit more specific to what they need to get back to, or mainly to the thing that kind of causes them pain. Because typically it's like there may be one movement that somebody has an issue with, but that doesn't mean like all of the movements involving that part of the body that hurt, bother them. So it's like, if it hurts during a push-up, well, but maybe it doesn't hurt during a row, maybe it doesn't hurt during a hands elevated push-up, maybe it doesn't hurt doing a dumbbell floor press, maybe it doesn't hurt doing and you can kind of go through the list of so many other types of exercises that are going to stress those same muscles in the same parts of their body that won't aggravate their symptoms. So it's like, and then if we can kind of do that, maybe we're just desensitizing their shoulder and they may look stronger when we test them, but ultimately, like, it doesn't even matter to me like what muscles that we kind of think are weak. It's like, well, how do we just overall help prepare this person for the things that they need to be able to do? So it's like we're almost asking the wrong question, I think, by kind of trying to compare, by trying to just examine like, does getting stronger improve pain? It's like, it doesn't really matter to a certain degree.
And then before you talk, Doug, just to jump in with that too, is like, if we're talking specifically about an athlete who has pain doing their sport and it's like a sports skill, and they don't change that sports skill with a skill coach, like it probably doesn't really matter what you do with them in a therapy setting, because the skill is probably the thing that's causing the issue. So for me, it's a lot easier to talk about that with a thrower, because like you don't throw unless you're playing baseball or football, like it's a pretty specific thing. It's not like a field or court sport where you're doing some different sorts of cuts and agility. And if it's like, it hurts when I throw, it's like, okay, take some rest and like get strong, and then like you just go back to throwing like shit because your technique is not good. Like it's probably not going to last very long, or if it does, it's kind of like, I don't know, it's by chance. And I'd rather not just let things happen by chance, and I'd rather get you either working with a pitching coach, or sometimes I have these younger kids come in and it's like I just have to go have catch with them and like see what they can do and see how they move, and I make one little tweak and then it's like, oh yeah, that feels a little bit better. It's like, okay, let's just practice this simple thing. And then it's like, if I don't address that, this kid's going to be back in, or, he's just not going to be happy. He's going to be injured the entire season, especially if it's now and it's the spring and they're going to play all summer and all fall. Like they're just not going to have a good time all year. So just talking about specifically with athletes with a skill, like just getting stronger isn't always going to help them.
Yeah. And Trevor made the point that like we usually don't have enough time with people to actually get them stronger. So like if you have somebody, let's say like they're, they went to the gym and they're deadlifting like 500 pounds, that's pretty strong. And then all of a sudden on one of their reps, they like throw their back out. So now they're not going to be able to deadlift 500, maybe even doing 135 is going to hurt them. So when you evaluate them, they test weak. And also there's going to be inhibition because they're in pain. Like when you test their range of motion is going to probably not be great either. Like when you try to like, flex and extend and laterally flex and rotate their trunk. So it's easy to say in that evaluation, well, like you're weak, you only deadlift 135 and you're immobile. But in those cases, like the weakness that you're observing and the immobility is the effect, not the cause of the pain. So that's why something like a clamshell can work, because it's a non-threatening movement. I think the point of this research is that there are no magic exercises, like anything that the exercise is arbitrary, anything that can desensitize somebody and get them to moving in a more, a less symptomatic way is going to be good. But I also, and you guys work with a lot of athletes too. So I work with a less athletic population than you, and people could say, well, you guys work with athletes where like performance and output is a lot more important, but even in someone who's, let's say, like their only goal is to be able to like walk up and down the stairs without pain, if we don't use the term strength training, we just say graded exposure, how you manipulate your exercise program, your graded exposure program, is to use the same principles as you would in strength training, just managing volume and intensity. So if I ask somebody, well, like how high are the steps in your building? And they say 6 inches, well, maybe for that person, as part of that graded exposure program, I might have them do a step up on like an 8 or a 10-inch step, because for them, that's a higher intensity. It expands their bandwidth of output. And then I might say, okay, well, how many flights of stairs do you have to walk up and down? Maybe as part of their program, I have them, do some kind of interval training, or I have them accumulate a workload that exceeds what they would have to do in a day. So they're kind of, again, over prepared. So I don't even want to use strength training, because then people are going to say, well, like you don't need to develop strength to be less symptomatic. But if you manage volume and intensity in your graded exposure program, that's kind of like using the principles of strength training without using that word. And the last piece is, there are people that like will see a physical therapist or rehab provider, and their only goal is to not hurt, right? It's not like an output-based or performance-based goal. But even those people, typically you're going to say, well, what hurts? Well, again, it works getting up out of a chair, it works crossing the street, it works going up and down the stairs. So there's going to still be a functional or a movement-related goal, which is why I think graded exposure is really important. And going after function is important. If someone is so debilitated that like, even if they're laying in bed, they're in a ton of pain, I don't know, like I would probably refer that person out. If they're in that much pain that they literally can't do anything, then you should be like in a pain management clinic, anesthesiologist office, somebody else. Like if you can't do any kind of movement, then like I think graded exposure is a big part of our profession. And if you can't do, like literally can't do anything, and I've had people who, like I had somebody recently who had really, really bad like nerve pain associated with a disc herniation. And like even like just a sit to stand out of a chair, a body weight squat was just, he was in agony. I sent him to a back surgeon, and he ended up needing, well, I don't know about needing, but he had back surgery, like somebody that I trust. So if this surgeon says that he needed it, I think that he did. He'd been like basically 5 months without any kind of relief with really debilitating nerve pain. But if you can't do anything movement related, anything like where you can't manipulate some kind of an exercise variable, like I don't identify as like a pain management person or an anesthesiologist. Like if you're in that much pain where you can't do anything movement related in any form of graded exposure, then you're probably, in my opinion, in the wrong office. So I think that like our profession is a profession of function, and graded exposure, a progressive systematic exercise program, which might look a lot like a good strength training program, is really, besides maybe some manual therapy and some education, all we can do. And if we're talking about like biopsycho social readiness and that kind of thing, a good graded exposure program helps to develop confidence, because you're systematically introducing risk and desensitizing somebody to movement and exercise to achieve a functional goal. If we literally can't do any kind of movement in a session, then again, I think that you're not in the right office, at least from a physical therapy standpoint.
Yeah, I think that's just an awesome point to kind of summarize everything that we're talking about today. It's like understanding like what we do as a, and regardless of what kind of professional you are, but what you do in your profession, what are the skills you have, what can you bring to the table to help this client in front of you actually feel better and accomplish their goal, whether it's just to not have pain when they're walking upstairs, whether it's to, whatever, not have pain when they're sprinting. It doesn't really matter. It just, our playbook is only like so big in terms of like what we can actually do within our scope of practice and our skill set to help that person get what they want. So we need to know like what is normal and what are normal responses to the things that we can do. And like you brought up a bunch of good points there, Doug. It's like if somebody's just so debilitated they can't even do like a hip bridge on our treatment table, it's like, well, because of this nerve pain going down their legs, like, well, then you probably shouldn't be here. Like that's pretty abnormal. Like that's something that's probably a little more serious than something that are, movement-based interventions or manual therapy-based interventions can actually impact and help.
Yeah, because you can't treat pain directly. I mean, all we can really do is treat proxies for pain. Like your body is in a threatening state, you're lacking range of motion, you're lacking strength or output because of inhibition. And we can do things to try to desensitize those variables. And that usually involves some kind of movement. But we're not like treating pain directly. So if there isn't some kind of functional goal to achieve, even if it's something as seemingly minimal as like getting out of a chair without pain, being able to pick up, a package, without pain, or walking up and down the stairs. But in my opinion, our profession is one of chasing function and achieving functional goals. And if someone is just so debilitated that they literally, like I said, they're in agony just laying on a table, maybe there isn't even pathology. Maybe it's more of a psychological consideration. They need to go see like a mental health professional. All these things kind of intersect, but I think our wheelhouse is trying to systematically regain function through exercise and movement. And like I said, if someone's on such a far end of that spectrum where they can't move at all, then they should be in a pain management type of setting, and not in a movement-based setting. So again, I think that it's important to be accurate with our language and say, strength doesn't necessarily improve pain or symptoms, but strength is also kind of a dirty word, and it has certain predispositions and biases behind it. If we say graded exposure, then people don't really disagree with that. And if we're not doing graded exposure, if we can't do that because our options are that limited, then that really takes away like the identity of our profession.
Absolutely.
Nailed it. That's enough on this. Just another update for you guys. By the time this podcast is out, we should have announced that we're moving our online continuing education platform to a subscription model. So we're pretty excited about it. We're going to be having new monthly content on a regular basis, from different things like long form written articles to webinars to new programs, protocols, new courses, different sorts of interviews with different people from the field, and a professional community where you can ask questions about some of the content, or post jobs and find different positions that might be available that might interest you. Really excited about that. You guys have anything you want to mention about that?
I would just say one of the reasons we wanted to do this is because we want to create more of that kind of community and group within our profession, and the people who we like to learn from and talk to, kind of just how the three of us always have each other kind of talk to and bounce ideas off of. We want to help bring that to people who don't necessarily have the access to other practitioners or coaches or clinicians who they work with to help kind of learn from. So we want this to be really interactive with everybody who joins it, because we want to help everybody in the group get better. We want ourselves to continue to get better and learn from the people who are a part of this thing.
Yeah, and I mean, even from like our own standpoint, we're continually hiring new people to work in our clinical setting. And I know when we were starting out, it was very difficult to kind of navigate the continuing education world, because there's so many different courses, but no one really talks about how to piece things together. So I would always encourage people to take individual courses, because that's how you learn. You've got to piece things together for yourself, but part of the goal of this is to piece things together for people and try to have like a lot of the resources that we think are important for sports-oriented rehab provider, in a single resource. So you don't have to like try to connect the dots on your own. Again, we encourage people to look outside of the content that we're creating, because we're not the only ones that produce relevant content. But to make it just a little bit less chaotic and more manageable, and try to piece all these various things that are important together in one resource.
Definitely more affordable too. Education is pretty expensive to begin with, and we had mentioned thinking of doing a more expensive mentorship program that we kind of just weren't really all in on, and we saw that it would be more expensive for people. I think this is definitely going to be a better model where we can still provide some level of mentorship, and potentially down the road still kind of offer something that might be a little bit more in depth. But I think we're more excited about this, and I think this is something that will be something we want to do and keep it this way for the long term, instead of just kind of figuring out what we want to do now and then kind of shape things later.
And hopefully reach a lot more people.
Yeah, I think we'll
impact more professionals as well.
Definitely help more people that we wanted. We're very lucky we had the mentorship we had, so we want to find other people that are interested and help them, and also kind of learn from them too.
Yeah, I mean, the idea is to really create kind of like a decentralized, low opportunity cost alternative to a more formal like residency or fellowship type program. Like, you're not going to get with this subscription service like a formal credential out of it, but The idea is to save a lot of time and money and get the same information and the same professional competence when you're done going through the material.
Yeah, and we want to get people from different disciplines to also help us, different sorts of specific coaches like sprint coaches and things like that, and get them involved so that it's like a one-stop shop type of thing.
Yeah, that's a good point. It's like good luck getting, a medical body to authorize CEUs from a non-medical professional. But I think that a lot of, the important like voids in our field are answered by outside the field. And that's why, it's like all we care about is just someone's competence and like what they offer from an informational standpoint, not the letters after their name. And so, like I said, it's going to be very decentralized, but hopefully provide people with the information they need to, confidently work with anybody from like a very like acute rehab scenario to further along in a return to play scenario and everything in between.
Awesome. Well, that's it for this episode, and we look forward to speaking to you again soon.
Thanks, everybody.
Thank you for listening to the Resilient Performance Podcast. As a thank you for listening, please use promo code PODCAST for 10% off our professional development resources at resilientperformance.com. Also, make sure to sign up for our mailing list to receive exclusive content and promotions.